So today I'll be talking about unpacking racial inequities in access to healthcare. And before I start, I'd just like to acknowledge the privilege that I've had to live on this land. I'll also like to acknowledge my funders. So in this presentation, I'll be, probably like chunking together around 10 different studies. And I'd like to acknowledge my funders, my Canada Research Chair, LevMax grant through Alberta Innovate, CIHR. There is a slide or two about the funding that I got from Government of Canada. And there's one or two slides from a study from PolicyWise for children and families. So Canada's population reached 1.5 million in 2021. It comprised of 4.3% of the total population. And 16.1% of the racialized population. We are projected to exceed 3.0 million by 2041, according to Statistics Canada. And we are generally younger and than the Canadian-born population. And 40.9% of the Black population was Canadian-born. And sometimes people say we have a Black community, and we have Black communities. So many communities within that, and if you go to one community, something may be different. So there has been a Statistics Canada report that reported racial inequities in Black people's health, finding inequities in terms of COVID-19. We had the highest age standardized mortality ratio of any racial group in Canada. HIV and AIDS is 15 times more in Black communities. So for every one person, every one white person that has HIV and AIDS, you probably have about 15 Black people that do. And perinatal outcomes, mental health, breast cancer. So Black people are more likely to die from breast cancer at an earlier age. And also, they also face a higher mortality. So, like for example, most people that die from breast cancer within the white population or the general population actually is, maybe an average of 50 years or diagnosed at 50 years. For Black people, they tend to get diagnosed, in their early 40s on average. Sickle cell disease, cardiovascular disease, stomach cancer, and several other types of cancer. And we are overrepresented also in the justice system and the child welfare system. So it is these inequities that my Canada Research Chair seeks to uncover. So the purpose of my Canada Research Chair is to conduct original research with Black communities, and I'll be presenting some of that, to co-develop action with Black communities. So it's a 7-year Canada Research Chair program. I'm sort of now in the second year, so I'm still like original research. Co-develop action is now springing up. Capacity building, I have a mentorship program for both high school youths and also graduate students and early career researchers. Not mobilize knowledge and also establish networks. So I'll be presenting some of the results that we've had in my studies, and I would say, we have about 10 studies. This first one is actually going to be coming up and there's going to be a press release, so it may be in the news. It's going to be coming up in Canadian Medical Association Journal. It will be published in March 23rd. So we found, we looked at disparities in prescription medication for Black people, and we found that there are disparities between white and Black people, but there's a range. It changes across years, but it remains the same, that Black people experience higher non-adherence to prescription medication. So when we think about it, we think, Canada is, things are free in Canada. It's a publicly funded system. So you go to your doctor and your doctor says, oh yes, you can come to me 10,000 times, and or your nurse practitioner, you go, but then if you don't take the medication, there's still not going to be any good from it. And this is one of the challenges we have, because black people are less likely to have insurance coverage, because of course black people are less likely to have a job that has insurance coverage, or even have a job, with job security. We, for this specific study, decided to split things up, and we decided, let's even see how it is with other racial groups. And even when we split things up, we still found that black people were still probably, at the lowest bottom of the hierarchy related to prescription medication. So this has implications for pharmaceutical drug coverage, and I would say that how the study actually came to be done, it was in part of my, idea to do this study, was around the time when pharmaceutical drug coverage policy was being implemented. I got a message from a senator who is now retired from the Senate, and she's a co-author on the publication, and she's like, oh, I want some data on pharmaceutical care. Can you help me do a literature review? And I'm like, there's no literature. There's no literature on that. And of course, if there's no literature, then I'll try to do it and uncover what exists. And then, when we opened the books and we tried to look at what existed, it was that there was really a big disparity. What we also found is, the most likely is that they don't even fill the prescription at all. We also looked at access to primary care, and this is, we just did a national survey. I didn't cover it here, of about 4,000 black people, black children and black youths across Canada, and this is also coming up. And in our survey, in this analysis, and this is analysis of, I'm sorry to say, Canadian Community Health Survey. All the analysis that I am showing from Statistics Canada is the Canadian Community Health Survey. Canadian Community Health Survey is one of the most popular and the biggest surveys in Canada. And the good thing about Canadian Community Health Survey, as opposed to other surveys, is that it specifically collects data on race. So because of that, I'm able to analyze racial groups. So we also looked at primary care access using exactly the same survey, which is the most commonly used survey for most of the analysis on different topics related to access to health care. And we found that by age group, that there were differences across age groups. Of course, the younger people don't feel like I need a doctor yet. There was also differences across across sex. So, I'm masculine, I don't need a doctor. And also that there was differences in terms of racial groups in people having access to primary care physician. And as I said, the analysis that we did, the recent survey that we did, we surveyed around 2,000, 3,000 youths. We are still in the process of publishing, completing the analysis for that, so I didn't show it here. But black youths, most of them don't have a primary care provider, either a primary care nurse practitioner or a primary care doctor. Most use walk-in clinics. So, getting a primary care provider is hard, or differences for black individuals. But then what? When we looked at wait times, we found a different picture for minor medical procedures. We found that black people had a lower wait time for minor medical procedures, so wait times less than 3 days or less than 6 days, than many other racial groups. So, we are still doing qualitative research to see, why this is, but my guess is the wait time is low because they are not waiting to see a primary care, they're just barging into a walk-in clinic and getting it done. We also looked at flu vaccination, and we know during the days of COVID-19 that two of the things that contributed to black people's inequities is socioeconomic disadvantage, and we also found that they had a lower flu vaccination, and that was the same too with this, that black people have a lower rate of flu vaccination, And that, I don't know if it's on this slide or another slide, that, younger black people also have a lower rate, and, men have a lower rate. So the black male youth, their rate of flu vaccination and also their rate of having a primary care provider is often less. And that has changed over time. Now, when we took this, we have an advisory committee of black community leaders across Canada that advised us on this. One of the things that they advised, and which we've not done yet, is let's look at what has changed since COVID-19 pandemic. So for this analysis, we've not done that yet. But in the future, that's what we're hoping to do is, has this changed with all the things that, especially related to vaccination since COVID-19? This is the newest one that we did, and I think we had a student, a visiting student that was a statistician from China that came to visit us for about 6 months. He just left in February, and he was looking for a project to do, and this was integrated into the project that he did. So we just finished this in February. So this is the first time I'm going to present about this, looking at also colorectal cancer screening among black and white people, and we're finding fecal test for colorectal cancer that it's lower in black people, and also colonoscopy. And when you look at this, the red sign shows where the populations that have a lower rate. The standard population of comparison is black male. The standard population of comparison, I think it's white here. So black people have a lower rate than white people, and also black women have a lower rate than white men, but white women have a higher rate of colonoscopy, of fecal test than white men. So again, I think one of the things I'm trying to now we have Canada's. I think we just probably have, or we are about to have, men's health policy that's just been announced. So I'm hoping that this actually addresses some of the gaps that we see in terms of men's health and use and access to services. Again, colonoscopy screening, we find in black people have lower rate than white people, and we also find in black men and women have lower rate than white men, but again, white women have a higher rate of going for colonoscopy screening. So some of the other things that I have done is looking at pap smear and mammogram screening, again with the same Canadian Community Health Survey. And actually right now we've moved from Canadian Community Health Survey, and now we've moved to CanCheck. The nice thing about CanCheck, and so in about 6 months, you'll probably start seeing me talking a lot about CanCheck. The nice thing about CanCheck is that it includes all, it has vital statistics, so it includes all people that died in Canada. And we can link it to census data, and census data has racial outcomes. And based on that, we can be able to see if there's disparities in people actually dying from different conditions. So right now we have a postdoctoral fellow on our team that is in the earlier stage of looking at cardiovascular, ischemic heart disease, diabetes, and some of these conditions. And I'll probably be getting more to look at and shed light on some of these conditions. But for this one, looking at pap smear and mammogram screening, initially we started with black and white. And initially we did black, white, and other, and then we realized the other had worse outcomes, and we are like, let's open up the other and see what was happening in the other category. Well, when we opened it up, it was actually, I think it was West Asia that was having some of the worst outcomes, and South Asia in terms of pap smear and mammogram screening. So there was disparities between white people and black people in pap smear, but in mammogram screening, Southeast Asian had a disparity with, were the only groups that had a disparity with white population in mammogram screening. But do you still remember that even though black people, there may be no statistically difference after you control? So initially when we did not control for factors such as age, income, black people had worse, so it was different. But then when we control for all the other factors like what's your age, what's your income, and so on and so forth, then there was no difference in mammogram screening, statistical difference. But still remember that black people, even with that, we still have data that establishes that black people are dying earlier and also at a lower age. In Alberta here, we interviewed black women to look at access to health care. And we found, some of the issues that they face with access to health care. And this was after the previous study related to pap smear, related to gender, the intersection of gender, the intersection of race, and their comfort level in feeling like the healthcare professional is culturally competent to be able to provide services for them. This was a while back in the days of COVID-19 pandemic where I looked at this information and misinformation among black people. So as I said, the days of COVID-19 pandemic, one of the challenges that we faced is, the government was like, we have to solve COVID-19. And if we don't, address the disparities that black people are facing in terms of having higher COVID-19 rate, having more death rate, we are not gonna solve this. So they were trying to look for ways to be able to address this. And one of the things is, vaccination. And disinformation and misinformation. So I did this study looking at COVID-19, online disinformation and misinformation among black people, interviewing black healthcare black community leaders. And one of the things that they said is issues related to distrust. And I think issues related to distrust also continues to affect issues related to influenza vaccination even to now. So distrust of the system. So, this quote I have, the person mentioned Tuskegee syphilis study. And who knows Tuskegee syphilis study was a study done a while back that, tested and followed black people to know the course of syphilis. The only thing, or a few things, is they didn't know that they had syphilis, so they're being monitored for syphilis, they didn't know. And then when they had syphilis, and as the syphilis progressed, there was medication available to actually treat the syphilis. They weren't given the medication. So they weren't told, they weren't given the medication. It had negative consequences for their wives. It also had negative consequences for the children that were born. So a lot of times we think that sometimes, some of these historical events are stuck in the, olden days, but some of it continues to affect, black people's use and access to health services now. During the days of COVID-19, I remember the government of Canada, one of the things that they did is they provided small funding to national and some community organizations to be able to actually address COVID-19 within their communities. And I was part, as I said, about Black Opportunity Fund, and we organized a town hall. And part of our strategy is to get healthcare professionals to say, see, I got the COVID-19, because there was news spreading in the community then that if you get COVID-19, it's 666 sign, and you're going to not go to heaven. So it was, I got the COVID-19 pandemic. I did not die. I'm still going to go to heaven. So you can go get it soon. And I remember in the small group, one of the things, we had a small group, and I remember there was a bunch of women from East Africa that were in the group. And one of the things that they asked us is this another experiment? Right? And so when you hear that question, it's not just a question that it is a question connected to the racial history that you guys have done this to us before, done a bunch of experiments, and now you're doing another bunch of experiments that is going to harm us. Also, during the days of COVID-19, I looked at the intersections. So I wanted to look at mental health of black youths during COVID-19 pandemic. And one of the things that I did is I had an advisory committee of black youth, and I usually have an advisory committee of black youth. And one of the things that the youths told me during COVID-19 is, wait, you've not asked the question. COVID-19 was not the only thing that was happening to us. COVID-19 happened, and at the same time, around the same time, we had, pictures of black men being killed, and with the Black Lives Matter movement arising to address that. So they said we had dual pandemics, right? And please put questions related to dual pandemics. So we ended up, I think this is either in CMAJ or I think it's Canadian Journal of Nursing, I'm not sure, I can see that well. We ended up having a paper on dual pandemics, intersecting influences of anti-black racism and COVID-19 pandemic. So looking at police brutality towards black people and COVID-19. So imagine you're a black male youth and you're locked up in your house because of COVID-19 and you can't get out, and then you open the TV and all the things that you see on TV all the time is someone like you being killed, and the trauma and the mental health impact of that. I did this. This was right before COVID-19, looking at the mental health of black youths, and we found issues related to mental racism and discrimination. So one youth said, I grew up with so much internalized anti-blackness. God, I hated myself. I wanted to be white so bad. I wanted to have straight hair. I wanted to have lighter lips. I wanted to have smaller lips. And this youth at the same time, spoke about, after this discussion, spoke about our experience of sleeping over in a friend's house and someone calling her the N-word and saying, your lips, and she, not just heard that, but also internalized it. And from that internalization, it continues to have impact on our mental health. And then some male youths will say, there's this perception that toxic masculinity is a man thing, is a black man thing, but it is not. And for me, as a black man, I am guilty before I'm proven innocent. So, you're walking and people think, you're just about to do something that is not the most appropriate. And when they go to mental health providers, some say that their mental health issues are not well being addressed, especially when it relates to anti-black racism. So I say, I'm experiencing anti-black racism. What did you say? Are you sure? And then they just move over to something else and don't address the fact that what I need to actually talk about is I am experiencing anti-black racism and I want you to help me deal with this. And food insecurity was also discussed during COVID-19 pandemic, and this is one of the things, sometimes you see some people appear in churches and you're like, they are coming to praise God. Well, yes, it's good to praise God, but sometimes it's also because there's food at church. And that's a place that you can actually get food to eat. So it was one of the things addressed, during COVID-19 when, there's, people's job, people were being laid out, there's no jobs, financial insecurity, and people leaned on the church. This is one thing that came out for some of the youths in our team. So some youths talked about sports and the role of sports. Not just, I think, oftentimes we think about sports as, just physical, but sports is a vector for social change. And it's oftentimes a way for black youths to actually release their pressure and the stressors that they face. And what some of the youth said is, when during COVID-19, the bars were open at some point. The basketball court, even though it's an open space, was closed, and we were not able to. And they felt there was, inequities along lines of age, not just in terms of race, for youths in general. But with all this, we still saw a strong level of resilience among black youths. And where do the youths draw their resilience from? Many of them draw it from their spirituality. So they'll talk about all the things that have happened to them during COVID-19 and all their negative and past experiences, and they'll say, we are Christians. We do have faith that God is with us. God is there to protect us. So I wasn't anxious at all. So their spirituality and their faith continues to be a buffer in terms of their stressors. And also community belonging is also one of those things that we can capitalize on. And there was another study that I did, this time not using Canadian Community Health Survey, but using Canadian Health Measures Survey. Nice thing about Canadian Health Measures Survey, I've only used it for one study, is that you can use it to do physical measures analysis on a wide range of topics, not just in terms of racial disparities. So if you're looking, for example, to know if there's actual blood work and there's differences in terms of diabetes and many of those things that can be revealed through blood work. The only problem with Canadian Health Measure Survey is the sample size is not big. The one that I used, our sample size about 60,000 a year. The Canadian Health Measure Survey, which physical samples, only has about 5,000 to 6,000 a year. But when I used it to look at immigrants, if there are disparities, not in terms of black, but in terms of immigrants. I couldn't do black on that study because of sample size issues. What we found, the two factors that we found contributed to mental health was income, so it's good to be rich. And the other factor is community belonging. When you feel like you belong to a community, a local community, a church community, then you're more likely to rate your mental health as better. And I think as nurses, and many of us, that this is actually, the good thing about this is amendable to social change, right? There are ways that we can promote community belonging. I went to immigrant serving organization, and sorry, I'm diverting a bit. I went to immigrant serving agencies when I did the study across Alberta, and I think I did about 3 or 4 focus groups with 3 or 4 immigrant serving agencies here, the biggest ones, and also in Edmonton. And when I asked them, okay, community belonging, so how do we promote community belonging? Guess what they talked about? Like different ones, I would just go to different ones, and they are repeating the same thing. I think about 6 of them. And I did about 9 different focus groups, parenting programs. And they said, when there's parenting programs, kids start talking together, parents start talking together, phone numbers start getting exchanged, and you have that natural environment that just creates community belonging. So what has been some of the activities of my Canada research chair to address some of this? So some of the things that I have said that I'm doing is conducting original research, such as many of the studies that I have said. I'm co-developing action, building capacity, mobilizing knowledge, and also establishing networks. So we are co-developing knowledge action through conversation cafes and African knowledge systems. So I currently have 2 grants, one by Canadian Cancer Society for $450,000, looking at improving breast cancer screening among black women, because of course, as I said, they're dying at the earlier age. So yes, if you have a family history, know that don't be going with the same standard of everyone. There is. So we are planning. We just completed focus groups with 104 women and community leaders, and we are currently in the development phase of a curriculum. Clinical nurse specialist is helping us with that, Masters Prepared, to develop a curriculum to roll across Alberta using conversation circles to improve screening practices among women, and also to support with peer navigators that support black women through the cancer journey. We're also thinking in terms of mental health of youth and children. We've done interviews of about 45 youth and also children. We use dance-based methods. That's on another day. And we are in the process now of developing a curriculum, and that's funded by CIHR, $400,000, that integrates African knowledge systems with Western knowledge systems to improve mental health. And when I think about African knowledge systems and mental health, some of the things that are important in terms of critical consideration is spirituality. So when people say, we know that God is going to protect us, respect, and community. Right? So we are not an individualistic culture. In my culture, if someone else, if we all come here, we are in the same clothes, we're all going to be all happy because, we are all together. In some other cultures, especially Western culture, if, there's 2 people in this room that wear the same clothes, the other person is going to say, I want to go, change my clothes. That's an individualistic perspective. We're also building capacity. So that is one, the Black Youth Mentorship and Leadership Program, which we've had 6 cohorts of that. We started in 2020. We've had 6 cohorts of that. We also have the Black Scholar Summer Institute. So last year we brought about 50 Black scholars to the University of Calgary. We provided them with intense 3-day training. We even took them to a lab to learn about practically how to use NVivo, practically how to use STADA software. We taught them, we had CIHR and SHIRK come and give 1-hour presentations. It was great. We are doing it again this year, and CIHR and SHIRK has agreed again to come. This year, though, we are moving to the downtown campus, so we are going to do it on the downtown campus. Last year, we did it at Alt Hotel, but we needed a bigger space this year. We're also mobilizing knowledge. So, people might have seen my face. The Registered Nurses Association of Ontario has within the last 1 month, published the best practice guideline on addressing anti-Black racism in nursing. And I was asked if I wanted my picture there. I'm like, okay. I co-chair the best practice guideline development group. That is me in a picture. On the lower side, we are doing a video now on developing a guidance document for healthcare professionals on how to address mental health in Black youth. So what do you do at the assessment phase? Even before you start the assessment, implementation phase, evaluation phase, and we submitted it for publication when it's out. I'll share it among the faculty. And I've also presented to the Parliamentary Standing Committee on Health on Child Death. They were doing a study a while back. They were doing a study a while back, and I presented there. I also co-chair the Public Health Agency of Canada Advisory Committee on Science. It's a new committee that has just been to advise the Chief Public Health Officer on how to integrate science and evidence into, I'm also part of the SHIRK Governing Council. Some of you may know this. I think on the far right is Mary Anyampoza, and Mary was here from Ghana, so we held a conference last year in Ghana, and that's the conference we held in Ghana. We also held a pre-conference when we trained early career researchers in Ghana, and those in front are prominent policymakers in Ghana, we may be holding something else next year. And also I also convene a Black nursing faculty network. So many of the Black nursing faculty members across Canada are part of this network that I lead. And really our goal is to build ourselves from inside out, right? To capitalize on our strengths. So sometimes we have workshops and things, to just strengthen our capacity. And I've also done work in terms of strengthening research methods. So I co-authored a Canadian Medical Association journal guidance document on how do you report race and ethnicity in research articles. So in the most basic sense, sometimes we still see in some of those publications when they're reporting race and ethnicity, they always put white first and everyone else after. No, you're not supposed to do that because WB comes before W, right? So that is really one of the ways that people don't know, that is really a colonial way of doing things that we get used to. Or the other thing you can do is, what we suggest is either list them alphabetically or have some rationales for listing them. So for example, if one was more significant than others, then you can list according to the level of significance, but don't always. Capitalizing, WB, indigenous, and those are some of the things, and also considering the intersecting determinants. So thinking about, what are the implications of some of the things that I have discussed? The implications include addressing contemporary and historical experiences related to racism, anti-Black racism. So as I said, things are not stuck in the past. It happens now. People experience racism and they need a way to be able to deal with it. They need cultural competence. When I say, I'm experiencing racism and I want you to counsel me on how to address this, how to navigate this, I want you to actually support me. Income as a determinant of health, and know that inequities and anti-Black racism will lead to income inequities in terms of people and the employment that they're able to get. Will also then lead to people's access or prescription that, that if they have drug insurance, and then will lead to actually if people are taking their medication or not, or at least purchasing their medication or not. And then it could then lead to negative health outcomes. So that is one of the straight direct path that some of my studies show that could be one of the pathways to inequities. Trust is very important. There has been issues of trust in the past, and sometimes, yes, you wonder why some of our healthcare professionals are not, some of our communities are not trusting healthcare professionals because of those historical issues. Afrocentric values and culture, so value and culture related to respect, related to community, related to spirituality. Sport integration in some of our approaches. Strength-based methods, so yes, we do have several strengths. And if I'm to talk about some of the several strengths, one of the most educated groups of women in Canada is Black immigrant women, especially from West Africa. They tend to be one of the most highly educated, and there's consistent, you can Google it, there's consistent evidence. Also in the US, if you see the average Cameroonian, Nigerian, Senegalese, Ghanaian, they probably have more education on average than the average white person. And those are some of the things that we can also build on. Religion and spirituality, ensuring that we do work with communities rather than on them, and also strengthening community belonging. So do not, minimize that parenting program that you're teaching people how to deliver, because those are natural environments that can actually support community belonging. And also mentorship. And one of the ways, and we talk about that in the guideline on addressing anti-Black racism in nursing, is the importance of mentorship. And one of the challenges we currently have is people tend to mentor people that look like them. Either you're mentoring people because they have similar interests, or because they have similar gender but you think it's because of similar interest, or because they have similar race because you think it's because of similar interest. And one of the ways that we can really, really address inequities is mentor someone that, be really, really aware of those in your mentorship circle, and mentor someone that seems different. And thank you. And sorry if I went over.